called portal venous hypertension. That's going to back up along the portal system. It's going to be responsible for allowing a lot of blood to congest in the spleen. So this is what the normal spleen looks like. Look at this spleen. Splenomegaly. This is a congested spleen. Reason it's big, blood can't drain into the splenic vein properly because of the portal venous hypertension. A couple other things you'll notice. If you look at the retroperitoneal cavity, you can see we've got fat radiodensities here. But in the peritoneal cavity, you'll notice that you have this intermediate radiodensity throughout. There's an air density, it looks like in the stomach here, but there are some other kind of radiodensity in the peritoneal cavity. What do you think that is? Looks like it's filling the whole belly. That's fluid. That's the ascites. You can see the ascites is filling it. You can see there's a good distinction here between the peritoneal cavity and the retroperitoneal cavity here, retroperitoneal space. Okay, let's summarize a few things. I want to look at the workup for cirrhotic liver. So we're going to get a biopsy of the liver to examine the extent of the cirrhosis. We might get a clue as to what's causing the cirrhosis, but generally you're going to see pockets of normal hepatocytes surrounded by fibrous tissue. The whole architecture of the liver is disrupted such that blood cannot flow properly through the liver. And as a result of a liver dysfunction, you'll find a few labs are out of order. Hypoalbuminemia. Albumin, remember, is one of the markers for liver function. It's not a marker for liver damage. It's a marker for liver function. Then we have AST and ALT. Those are markers for liver damage. If there's something causing a constant inflammation of the liver, you'd expect AST and ALT to be elevated. Sometimes that is referred to as a transaminitis, because AST and ALT are transaminases. They're elevated because of inflammation of the liver. So there is this slang term that's used sometimes. It's called the transaminitis when the markers are elevated. The clotting factors are not being produced. There's a coagulopathy as a result. And so the INR levels increase. Do you know what INR is? International ratio. It's a standardized clotting time. So the INR you expect to be increased. Hyperbilirubinemia, of course. There's a thrombocytopenia. And that occurs for a couple of reasons. The number of platelets in the blood are decreased. The spleen is enlarged, and that enlargement of the spleen is associated with some additional spleen activity. So the spleen is trying to sequester platelets. Also, because the liver is not functioning well, there's a decreased production in thrombopoietin, which is this hormone that produces platelets, or helps produce platelets. And of course, there'll be various signs of portal venous hypertension that we pointed out previously. To determine the etiology, you might already know the etiology. Maybe he's an alcoholic, that won't require much of a workup, but generally we'll screen for other causes, particularly if the reason is not readily apparent. So we get hepatitis serologies, if there are some sort of autoimmune antibodies are being produced. Ferritin, that will give us a clue about hemochromatosis, ceruloplasmin. That's the diagnosis of Wilson's disease, and of course the alpha-1 antitrypsin levels. Any questions on that? Okay. That's the case. Then we're going to talk about gallstones. These are cholelithiasis, chole referring to bile, lithiasis meaning stone. It's a common condition. 1 out of 5 people have gallstones, but fortunately only a small fraction of those individuals actually display any kind of signs and symptoms. Most of the time, these gallstones remain in the gallbladder and they remain asymptomatic. sometimes these stones will block the outlet of the gallbladder. If that's the case, then there's a mechanical obstruction of the gallbladder. The gallbladder contracting against that obstruction. It hurts when the gallbladder contracts against the obstruction. As a result, sometimes people will feel right upper quadrant pain. Sometimes the pain feels constant. Sometimes it is colicky, meaning it comes and goes. Also, sometimes the pain is referred to the right shoulder. The pain is most likely to occur after ingesting a fatty meal, maybe an hour or two postprandial. The fattier the meal, the more likely the gallbladder will be, more likely the gallbladder will contract. So typically, as a result of a fatty meal, the gallbladder will contract against that obstruction, and people will feel some pain. Okay, so we also have some other diagnostic signs. Murphy sign, if you learned about Murphy sign. Okay, so that's basically you're pressing down in the right upper quadrant. You ask the person to inhale. If the person's inspiration is suddenly halted, that's a positive Murphy sign, and that just means there's some tenderness there in the gallbladder. So we got two types of stones. We've got these cholesterol stones, and we've got these pigmented stones. Cholesterol stones are much more common than the pigmented stones. 80% of stones are cholesterol stones. So if someone tells you they've got gallstones and they don't tell you anything else, you don't know anything else about the individual, your guess is going to be they're going to be cholesterol stones. And you'd be 80% right. You're right 80% of the time. Pigmented stones pretty much make up the remainder. The cholesterol stones are made out of cholesterol monohydrates. It's a crystallized form of cholesterol. The pigmented stones are made out of calcium unconjugated bilirubin. Okay, so let's take a look at the cholesterol stones first. These are the more common. All right, well, there's a lot of cholesterol in the bile. Bile, of course, is stored in the gallbladder. There are a couple of conditions that make cholesterol crystallize out of solution. Three things have to be present to cause cholesterol to crystallize out of solution. First of all, the bile has to be supersaturated with cholesterol. Cholesterol is ready to come out of solution. There has to be a nucleus on which the crystals will begin to form, so that's called nucleation. It has to be favorable. And once the crystals start to form, they have to remain in the gallbladder long enough to get some significant size. So nucleation, supersaturation, and stagnation of bile are the three conditions necessary to promote gallstone formation. All right, some significant risk factors you could recognize. The older you get, the more likely stones will develop. It's much more common in women, particularly women of certain ethnic backgrounds like Native American women. The condition also is more likely if the person's more hyperestrogenic, i.e. if they're a little overweight, they tend to be a little more hyperestrogenic. That can favor the formation of gallstones. There is a mnemonic for individuals who typically develop cholesterol stones, fat, 40, female, fertile, flatulent. Okay, those are the 5 F's. Fat, 40, female, fertile, flatulent. That's your typical demographic that's going to develop these cholesterol stones. Rapid weight loss, really that's most likely a result of cholestasis. So if someone's losing weight, they're probably not going to move as much bile as they normally move, and it'll remain stagnant in the gallbladder. And that's one of 3 factors necessary to form cholesterol stones. All right, let's have a look at these stones. And cholesterol, it's a fat. It's a fatty molecule. It's got a steroid nucleus. Pure cholesterol looks yellow because it's fatty. So cholesterol stones tend to look yellow. This is an example of some cholesterol stones. You can see we've got 4 different cholesterol stones here. What we're looking at is a resected gallbladder. It's a product of a cholecystectomy. There's the dome, there's the neck. The gallbladder has been opened. You're looking at the mucosal surface of the gallbladder. You can see it's stained with bile. Inside the lumen, we've got 1, 2, 3, 4 stones. You'll notice that each cholesterol stone is made out of these smaller crystals that are in aggregate. So when these crystals start to form, you can see they're pretty small. They have to have time to aggregate in these stones really to make a difference. And so you've got supersaturation of cholesterol, you have stagnation, and you've got nucleation has to be favorable to make these kinds of stones. Cholesterol stones in their pure form are yellow, and those certainly are yellow. They're not always this clearly yellow. Sometimes they're mixed in with a lot of bile and they have a kind of green color to them. They may look kind of black, in which case they're sometimes confused with pigmented stones. But these pure cholesterol stones are yellow. As you know, fat is radiolucent. Okay? You're familiar with the 5 radiodensities. You learn about that in radiology.
Yep.
The 5 radios. So you've got air densities and fat densities. So fat and air are pretty much on the lower scale of radiodensity. Typically in a plain film radiograph, these cholesterol stones are fatty. There are 2 radiolucent for you to identify directly. However, you can see them with contrast agent. If you use a contrast agent that's secreted into the bile, you can see the stones as filling defects. Let's take a look. This is not something we would now normally perform today, but this is called a cholecystogram. It's not a completely obsolete study, but it's not something we would do normally. It is a procedure where we fill the gallbladder with contrast agent. We can do this just by giving the contrast agent IV, eventually gets secreted and wind up in the gallbladder. This is a plain film radiograph in which the gallbladder is filled with this cholesterol and this radiopaque dye. And again, you can see there's the dome of the gallbladder. The neck is over here. There's a little accessory pouch on this gallbladder. That's normal radiation. Background ribs and air densities in the GI tract. If this gallbladder were filled with cholesterol stones, you wouldn't be able to see them directly without contrast. This is a gallbladder that's filled with contrast. You can see the contrast is remarkable for filling defects throughout the entire gallbladder lumen. Those filling defects are generated by cholesterol stones. So you can see this gallbladder is filled with cholesterol stones. Again, typically this is not something you would necessarily do, this type of study. This is more for academic reasons. I'm showing you this. Probably the first study you're going to do is an ultrasound. So just perform an ultrasound. Since it's so readily available, it's not necessarily the most sensitive and specific study to perform, but it is readily available, so we just do an ultrasound. So I'll confirm whether or not we can actually see a stone. Negative result doesn't necessarily rule out stones. Okay, those are the cholesterol stones. Okay, specific workup. Again, they're yellow. Sometimes they can be mixed together with calcium. If that's the case, they're radiodense. But again, you can't bet on them. Most of these are radiolucent. Any questions on cholesterol stones? Most of the balance there is made up of pigmented stones. Pigmented stones are made out of calcium unconjugated bilirubin. Anything that increases the unconjugated fraction of bilirubin would tend to promote the formation of these pigmented stones. They got calcium in them, they're radiodense. You can actually see these stones without any contrast agent at all. Pigmented stones are so called because they're black. The pure pigmented stones are darkly pigmented black. This is a resection called a Whipple resection. It's some procedure called for used for pancreatic cancer. But we have here gallbladder. You're looking down at the mucosa. You can see the dome. The neck of the bladder is up here, and again, you can see that you've got a stained mucosa here, and you've got these 3 pigmented stones. Those are calcium unconjugated bilirubin. As I said, they're radiodense for you to see independently. You don't need a contrast agent. So if you just take a plain film radiograph of the right upper quadrant, you might see them. And again, you can see we've got kind of an outline of the gallbladder, and that's because the gallbladder is filled with calcium and unconjugated bilirubin stones. And again, this is a plain film radiograph, no contrast agent used. You can clearly see them. And probably the first thing you're going to do to work up any kind of stone, whether it be bilirubin, whether it be unconjugated bilirubin stones, pigmented stones, or cholesterol stones, you're going to do an ultrasound. So here's what an ultrasound looks like. You have surface of the skin is here. There's the liver. There's the gallbladder. You can see the gallbladder is remarkable for an anechoic region. It means there's no echo. It's dark. It's filled with bile. So there's no acoustic impedance mismatch. It's going to be this kind of black appearing area here. But you'll notice there's this hyperechoic focus right here. It's reflecting sound very dramatically. That's, of course, a stone. Now, if you saw this in isolation, you see a stone like this, ultrasound doesn't tell you anything about the radiodensity of the stone. So, if you saw that, which kind of stone do you think that would be? A cholesterol stone. Again, you'd be right 80% of the time. So that's probably a cholesterol stone, although I can't verify it with an ultrasound. But you notice the reflection of sound is so intense that just behind the stone, there's actually an acoustic shadow. So much sound is reflected, there's actually a shadow behind it. Over here, this is a plain film radiograph. It's called the kidneys, ureter, bladder, or KUB. And up here you can see this radiodensity in the gallbladder. That's a stone. If you had to guess, what kind of stone is that? That's a pigmented stone. It's radiodense. So chances are that's a pigmented stone. You have more information. You have the radiodensity on this stone. It's probably not a cholesterol stone. Okay, so we have ultrasound observing the stones. You can also see some other effects. Maybe the bile is very thick, which described as sludge. You might be able to see that. You also might see some fluid around the gallbladder, some pericholecystic fluid. That might mean there's a little chronic inflammation in the gallbladder. Okay. Also, you might evaluate the biliary tree. Remember I said you can do that with a HIDA scan. HIDA scan is a nuclear scintigraphic scan. We administer this radioactive agent. It is filtered by the liver and is secreted into the biliary tree. Eventually, it should get into the gallbladder. So we can see here, we've got the liver here. This is the scintillation image we're getting from the scintillation camera. You can see we've got an outline of the liver. It's not a very good resolution, but the scintillation scans are not used to assess anatomy. They're used to assess functionality. And you can see there's this radioactive material that's shown up here as dark areas accumulating in the liver. You got a perfect outline of the liver. In about 15 minutes, you can see the contrast agents concentrating in the various ducts and the gallbladder. So we can see our gallbladder. Again, 20 minutes later, 25 minutes later, 30 minutes later, you can see the common bile duct pretty clearly. It looks like whatever's going on here, the gallbladder is patent. You can get some contrast agent in there. You can see the duct is pretty patent. So again, the ISA scan is just used to evaluate functionality of the tree. It's not to give you good, pretty anatomy pictures. Acute cholecystitis, which could be caused by an obstruction of the gallbladder due to a stone. You'll see there's no way to get this contrast agent in the gallbladder because the gallbladder's inlet is obstructed. And you can see the liver, 15 minutes, you can see the common bile duct. This is part of the duodenal sweep here. 30 minutes, more of the duodenal sweep, 45, 60 minutes, you can actually see some lower GI tract, 90 minutes, you can see, again, some more lower GI tract. You don't see the gallbladder anywhere in any of these images. And so it's obstructed for some reason, and in the right context, you can conclude that you can at least say that's consistent with a diagnosis of obstruction, and usually you're assessing that for something in the context of acute cholecystitis. Acute cholecystitis is just acute inflammation of the gallbladder, usually caused by a gallstone. Any questions on that? Okay, we can also see a obstructed gallbladder with a CT scan. Okay, is the CT scan showing you some features of an obstructed gallbladder? So you can see here's a CT scan within, almost within normal limits. If you ignore the spleen over here, anterior, posterior, right, and left, you can see again the liver outline. This is psoas muscles. Here's the gallbladder right there, normal size. Over here, you can see an obstructed gallbladder. Again, the liver, we're a little lower in the pelvis. Liver, and you can see some kidneys here. That's the descending aorta with a little calcified atherosclerosis in it. Some GI structures here. That's the gallbladder. And you can clearly see it's distended. You'll also notice there's a radial density in there, and presumably that is a pigmented stone. You can see on CT scan. Any questions on that? Okay, let's just briefly mention cholecystitis. So cholelithiasis could cause cholecystitis. Just because someone has gallstones doesn't mean they have a cholecystitis. That is usually the result of an infection caused by the gallbladder being obstructed. Normally, the gallbladder can constantly flush itself of bile, and sometimes that bile gets contaminated by bacteria in here. If the gallbladder can flush itself constantly, there's no time for bacteria to grow and cause an acute inflammatory response. But if the gallbladder is obstructed, then the gallbladder cannot flush itself, and there is an opportunity for the bacteria, usually things like E. coli, to colonize the gallbladder wall, and the result is an acute cholecystitis. Acute cholecystitis will probably present with a history of right upper quadrant pain. Maybe it's colicky, but it will progress to a fever, maybe nausea and vomiting, and a leukocytosis. Basically, all the signs and symptoms of inflammation. If the common bile duct gets obstructed, and it might by a gallstone, there'll be a conjugated hyperbilirubinemia that results, of course, in jaundice. There are some other findings. Usually, the abdomen's pretty rigid. The gallbladder on the CT scan will probably be enlarged, as we've seen before. When you perform a cholecystectomy, cure for this is just simply to remove the gallbladder, perform a cholecystectomy. The gallbladder will probably be remarkable for clear erythema, all the signs of inflammation. There might even be some hemorrhage. So there might be some hemorrhagic lesions in the gallbladder. Usually you find a stone in the neck of the gallbladder, and that's the obstruction causing the acute cholecystitis. Okay, sometimes pus will accumulate in the gallbladder. The wall of the gallbladder, again, might be thick, edematous, hyperemic, again, all of the features of inflammation. CBC, remarkable for leukocytosis, left shift. Bilirubin levels might be elevated if the stone is dropped through or block the common bile duct. And you want to check an AST, ALT level. It's possible that the inflamed gallbladder could be causing secondary damage to the liver. The gallbladder is right on top of the liver. Not a stretch to think that some of the inflammations involve the hepatocytes around the gallbladder or the secondary. Okay. Any questions on? So, cholecystolithiasis, that's just a fancy word for a gallstone in the common bile. These stones sometimes will make it out of the neck of the gallbladder. If they do, going down the common bile duct. The most likely place they'll get stuck, if they get stuck, is going to be right at the sphincter of Oddi. That's that smooth muscle ring that guards the ampulla. That's a bottleneck, so if something gets caught, it's going to get caught there. Okay. That happens. You can expect a hyperconjugated, conjugated hyperbilirubinemia that results in jaundice. There might be some biliary colic, and they might have some colicky pain. The problem that's most concerning when a stone gets caught at the ampulla is that it may also obstruct the main pancreatic duct. If it obstructs the main pancreatic duct, that could cause a acute pancreatitis. So let's take a look at this. Okay, so we have a lot of different stones that can form here. Again, these stones sometimes will swing down here, they'll break loose. If they're going to get caught, they're going to get caught right here at the ampulla. Now the problem is, not only does that block the common bile duct, resulting in a conjugated hyperbilirubinemia, but it also will block the pancreatic duct. The pancreatic duct is also blocked because it merges with the common bile duct. If that happens, then the pancreas is going to be backed up. The pancreas gets its duct obstruction. Sometimes that will result in acute pancreatitis. You see that right up here. We got the duodenal sweep here. There's the common bile duct. There's the main pancreatic duct. Again, they typically merge like this. And the problem with the stone is it's likely to get caught right at the sphincter of Oddi. And that'll block the common bile duct, the main pancreatic duct. The main pancreatic duct gets obstructed. Fat pressure develops into the pancreas, and that can cause premature activation of the pancreatic